Here we have one question. The question is, does the ENT doctor do skin testing for allergy?
No, we don't. We normally refer to the census document was actually formulated that we could actually work hand in hand, with our allergy colleagues, with our allergy colleagues, as well as from the Department of Pediatrics, as well as from the department. We normally refer them to the allergists to do it. We normally refer them to the allergists to do it.
We have another question. How long do patients have to be off any meds for allergic skin testing?
As I mentioned earlier, should be off for about 4 to 6 days.
Okay, we have another. Randy. What is your experience in finding what causes or treatment of allergic rhinitis?
I have very good experience, and I think it's going to be a first-line treatment, a combination of anti-leukotrienes and antihistamine in a single medication. It's going to be a very good choice. In fact, it was incorporated in the latest ARIA protocol, where it was not indicated in the very first one in 2001. So I'm very happy actually with the results using a combination.
And then another question is, are there new treatments in the horizon for allergic rhinitis?
Yes, as I mentioned, there's an anti-IgE medication, omalizumab, as I mentioned earlier. Unfortunately, we need more clinical trials on allergic rhinitis because clinical trials on the anti-IgE medication on asthma. So, but that is something very promising in the horizon.
Okay, we have many questions here. Another is, at what point will you consider nasal ciliary biopsy to ciliary dyskinesia?
This will probably be in patients who have severe, who seem to have some severe rhinitis symptoms that don't seem to respond to medications. Together with other comorbidities, because a lot of patients with primary ciliary dyskinesia will have other comorbidities like hepatitis media with diffusion. They may also have chronic respiratory conditions together with asthma. And I would probably begin to suspect, as you can see in the algorithm, they no longer restrict one of the articles. You will see that when there is a severe uncontrolled allergy, it's time to actually investigate for other possible things. And one of them is primary ciliary dyskinesia.
Okay, as of 12:51 today, we have 54 attendees, and from live stream, we have 6 participants, 3 from the Philippines, 2 from the US, and 1 from Canada. Do we have other questions? If there are none, thank you, Dr. Lopa, for the very engaging discussion. As a summary, we learned that history and physical examination is very important, as well as nasal. You also told us when to do allergy testing. You showed us the ARIA classification and treatment algorithm. You also touched on immunotherapy, very important topic of patient education in the treatment of allergic rhinitis. Also, we learned today about the new disease or local allergic rhinitis. Thank you very much, Dr. Lopa. There's one more question. Last question. Okay. I often see allergic rhinitis and sinusitis as comorbidities. When do you decide to start antibiotics in the absence of local signs or fever?
Yeah, that's a very good question. Actually, when you speak of allergic rhinitis, I think the more proper term is sinusitis, because the lining of the nose and the lining of the sinuses are practically one and the same. And any inflammatory condition happens in those happens in sinuses. So I think the more appropriate term is really allergic rhinitis and sinusitis. But when do you employ, when you start using antibiotics, it's usually, you need that this is the time that you actually need to do an endoscopy in the patient to see findings, endoscopic findings that would suggest a superimposed bacterial infection, such as a mucopurulent exudates in the middle hiatus, swollen or edematous middle hiatus, probably polyps, inflammatory polyps. And that's the time I probably start giving antibiotics to. Because it has been shown that patients with allergic rhinitis, patients with allergic rhinitis are 4 to 5 times more likely to develop a bacterial infection from a viral condition cold than patients who do not have allergic rhinitis. So they're actually 4 to 5 times more likely to develop a bacterial sinusitis. So we should always be on the lookout. So it's not only in terms of time and duration of the symptoms, but it's also based on the physical examination. That's when it also becomes very important. So you can actually visualize the results much closer.